Dr. Sarah Coll, orthopaedic surgeon based in Cairns in far north Queensland, and tonight I don't normally talk at these talks. We normally have Allied Health, and they're in the audience this evening, but tonight it's my turn, and I decided to pick a topic that wasn't considered very orthopaedic, and I chose this title, which probably is not really the title that I meant, but I thought maybe it's not the best title, but I thought I could have tried this one as well. But what I really want to talk about is the neuroanatomy of emotions, and see if I can apply it in some way to the practice of surgery, and see if we can have a conversation about what you guys think about it as well. So I guess what I wanted to start with was a little bit of audience participation, and you're not allowed to answer if you actually know the answer. My first question was going to be, what is an emotion? And I guess I want to hear about it from the experience of having an emotion. What do you think an emotion actually would be? What is it?
A feeling.
Did you say don't?
A feeling? Didn't I say don't?
Yeah, you said if you don't know, don't.
A feeling? That was a trick question. A feeling what?
Like in response to something.
Yep, I like that. Good. But what does it feel like? What do all emotions have in common that they feel like?
A sensation?
Yeah, I think so. It's like everyone knows what an emotion is, but I don't know how to define. I mean, I know what it feels like, I know what it looks like when you've got it, but I don't really know what it is.
So it's a personal interpretation of an action or you receiving.
But doesn't that sound so vague? Like, I would have thought that we'd be able to get to something really, like this is a bone, this is an emotion, and I don't feel like we can. Like, I don't, like with my research.
Because emotions, aren't they interpreted by the brain?
Well, that's where I'm going. You go. Yay!
I didn't know. I haven't read this at all.
So why do we care about emotions, and who cares about emotions? So I found a definition, and it basically is what you said. It's a brief, I thought that was interesting, psychophysiological response. Well, that's like an intellectual and a physical response, which is coordinated, such as you get sweaty, or you get a tremor, or you feel like a sinking feeling in your body, which therefore is autonomic and hormonal and neural. So we're talking about three systems at once: the hormone system, the brain, and the autonomic nervous system, so the parasympathetic, in response to a trigger, right? So it's a thing that happens to your body that in response to a trigger is an emotion, which then results, generally speaking, in a behaviour. It's cognitive behavioural theory. So something happens and you have an autonomic, hormonal, neural response, and then you do something. So that's an emotion? I don't think that's what an emotion really feels like. That's what I don't feel like that's what I'm doing. I don't feel like I notice a trigger, and I don't feel like I do something. I feel like I have a feeling.
I think that the word trigger is what you're having difficulty with.
Go on.
Because you're interpreting that a trigger is an external situation, an environmental.
True.
Whereas a trigger could even be a memory.
Yeah. Yep, internal. Yep.
Yeah.
Yep, that's true.
Or even a subconscious association that's been
So you don't even recognise that the trigger happened. Yep. And so then I tried to find a definition of what a feeling was, because the way the psychologists talk about it, they talk about a feeling as a different thing to an emotion. And so this is what I felt they were describing, was that you have a conscious experience. So I feel angry. So now I'm starting to have a bit of a perspective over this psychophysiological response. Am I on track? You're nodding very little bit.
Feelings aren't really my thing.
That's a great answer. So then, what is a mood, right? So psychiatry talks about mood. So psychiatry talks about mood and affect. So what they are looking at is like your baseline, who is this person? on an everyday sort of basis. And what they're trying to do is set up the DSM-3 criteria, which it puts a lot of emphasis on mood. So I have a depressed mood, I have an anxious mood. So they're sort of trying to work it, so then there's a definition of what a mood is. Well, I think that sounds a bit more like it's, the reason why I'm mentioning it is because it's a long thing. It's like a persona, which means that an emotion has to be a brief thing, right? So a mood is that long experience of a phase or of an episode of your life, whereas an emotion is that instantaneous psychophysiological response. Does that make sense? Am I getting there? So why do surgeons care? Well, maybe there's some triggers in my environment around me that maybe I haven't really noticed. Like things like I've got sharp instruments that I routinely use on people, and maybe, obviously not so much in this office because it's a funny little Queenslander, but, maybe in those clinical environments with those sterile, we put up nice big reception desks that people have to look over. We put, come on in, take last seat standing. Come on in. What around me might be considered a trigger. The other thing is that there's humans in the environment around me, and they might be having emotions as well. And I can't manipulate them or control them, or I don't even potentially have any influence or ownership of them either. So I have patients who are in pain, who are under pressure in a strange environment, trying to fill out forms when sometimes they can't really read and write, who have been told to come and see me by someone who potentially is almost a stranger, like a GP or a hospital doctor, and they're processing all of that while I'm trying to extract a history about their injury, which they had 6 weeks ago, and they can't quite remember exactly where everyone was and exactly what was happening. So I've got a trigger, I've got a patient in pain, I have a team who might have emotions sometimes, not just in my clinic, but also in my operating theatre. Operating theatre I feel very comfortable in, but some people find it very sterile and dry and maybe a bit confronting. Big lights and funny clothes that the patients have to wear. They complain about them a lot because they open up at the back and they feel very exposed. And then the team are, generally speaking, quite obsessive, controlling, very focused, hyper-focused people that are there because that's their personality and that's their, background. And so they're high-performance people who are trying to do a job in a resource, limited environment with other people around them who are also trying to do a really high-performance job. Patients seem to have emotions. Can't seem to control that. And sometimes surgeons even have emotions. And sometimes surgeons have emotions that may not be appropriate or may not be considered appropriate in the surgical environment. So we get a lot of feedback that we have problematic surgeons that are having emotional experiences or expressing themselves in behaviours based on their emotions that are considered inappropriate. I also tell people to rest, and I think that's a significant, something I've been thinking a lot about recently, is the blasé approach we have to prescribing rest. Here's your brace, here's your splint, don't do this, don't leave the house, you've got to rest at home, you've got to keep it clean and dry. And the patient can get a little bit overwhelmed with the experience of not being allowed to be themselves. And then I was like, well, maybe one person in this relationship or these series of experiences should maybe be self-regulating. I'm like, I don't want it to be me, but maybe I should think about that. And then maybe I should be able to think about how to support and encourage other people. So I wanted to think about, based on David's talk, I wanted to think a little bit about the neuroanatomy of what an emotion really is. And I was thinking a lot about pain as an example, and so what we were talking about was the trigger, which in the example of pain is say a hot surface, but could be me walking past my father's gravestone. So I have a trigger, I then detect a threat in the amygdala, which is part of our lower brain. So it's very loud.
Sorry,
used to get triggered, but I don't anymore. So the amygdala is a very common organ across a lot of different species, and it's a very instinctive, responsive organ. So it's like a wake-up organ. And then we've got the hippocampus kind of then starts to contribute. This is all in microseconds, and it's like, maybe we've seen this before, maybe this experience, something like this has happened before. The hypothalamus then switches on that hormonal response, switches on that autonomic response, wants to regulate that, and now we've got a reflex, right? So we've got an external input, we've got this lower brain processing, and then we've got an action, right? So we've got a behaviour, is probably the best way to describe it. But we have an opportunity to be the spectator over our lower brain by using our prefrontal cortex. So we can detect a physiological response, and that's where we start maybe detecting a feeling. So we're now starting to identify that this emotion, this physio-psychological response, we've got an opportunity to identify that and create a feeling, and maybe we can have a little bit of a decision about what sort of behaviour. So with respect to the pain side of things, David, and tell me if I'm wrong, we've now got a decision about how to respond to the pain. Is that right? Am I on it?
Yeah, and it can be conscious or subconscious.
Yeah, okay. Yeah, so it's not about sort of creating you know, this is your pain, you've got to control it. There's more elements, more nuances to it than that. Yeah. So we've got an opportunity, but I'm not saying that I'm a monk and I'm going to be able to control every single emotion that I have, because clearly I can't, if you know me. And so we've got an opportunity to be an observer over this. And so the idea is that maybe if we can tap into this subsequent pathway, so we've got this lower brain pathway that's happily doing all the things that we want it to do, and maybe we can manage our behaviour by activating this prefrontal cortex. And then maybe we could make decisions, maybe we could have some empathy, and obviously part of all of that would be some self-awareness. Now, I guess the reason why I'm introducing that idea fairly gently is because I think it's extremely difficult. And I certainly, when the artery starts spurting during the operation, it is very difficult for me to engage my prefrontal cortex. It's all instinct, and a lot of times I have to be trained to a point whereby I can do a lot of things instinctively, because my body just does I don't even really know about it. Having said that, it is really helpful for us to then debrief afterwards and work out, next time we get this through, next time the artery starts gushing, these are the things we want to train our subconscious or our lower brain, that sort of automatic processing to do. And these are the autonomic responses and other responses that we don't want to happen. We don't want to sweat into the wound, right? Ideally. And what about the neurotransmitters? I guess the way I see neurotransmitters, they're critically important, and I totally understand that they're between nerves, but I also think we're sort of treating them a little bit as of a soup, in that, if you eat some tryptophan, you'll feel better because you'll have more of this neurotransmitter, and if you don't do that, you won't have enough of that neurotransmitter. So there's the neurotransmitter component, and then the capacity of the brain to have these neurotransmitters around. And so the theories are that dopamine is the reward neurotransmitter, and serotonin allows us to manage our impulses, and norepinephrine revs us right up, and oxytocin, we feel more empathy when we get touched by people who are close to us. And then of course we've got the GABA glutamate inhibition, excitation, part of the soup as well. So all of this is actually going on at the same time. So it's not just simply a pathway, there's also that capacity of the pathway to transmit quickly, easily, and effectively. Well then, what's stress? So when I'm stressed in an operating theatre, day after day after year, what's that mean? Well, that changes a few other things. So my hypothalamus, which was right at the very beginning, hippocampus, hypothalamus, will stimulate the pituitary, which will release, sorry, the sun's going down, cortisol. And the problem with cortisol is that it starts giving us a bit of brain fog. So we start not being able to think quite so clearly with that whole prefrontal cortex. So this system is running in parallel. This is the hormonal system, and then there's the autonomic system and so the three systems running simultaneously. So why do people go and see psychologists? The work cover pays for heaps of psychologists. What on earth are they doing with my patients? Well, one of the things that is part of their enormous toolkit is this concept of cognitive reframing. So what we're now trying to do is we've identified maybe that we've had an emotion, we've identified that there was a trigger, and now we've got a feeling, and now we can think about, well, what can we do about the feeling? So can we sort of try and wake up the prefrontal cortex? So what do they do then? So they can facilitate emotional regulation and wake up the prefrontal cortex and wind down that amygdala, that basic response. And this has actually got some science. Back in my day, psychology had very little science associated with it. It was lots of big studies on multiple people, and the reason why I mentioned this is fMRI, so that's functional MRI scan. So that was quite an innovation 20, 30 years ago, whereby we can actually watch what the brain's doing. So then they keep telling the patients to breathe. Why they're breathing all the time, we get patients who try and do that during operations and things like that, and it is very poorly accepted. Can I just reinforce? Very poorly accepted in an operating theatre that someone might want to breathe or might want to perform any sort of personal meditation as part of their operation that is not facilitated. And what that does is by just actually focusing on diaphragmatic breathing, so for us, we just understand that that's using the diaphragm to breathe rather than the rib muscles, you can actually reverse some of this hyperactivity. And then maybe the patient can start noticing the feelings and start with that awareness of the feelings and then start thinking about managing them. So obviously that's got utility in theatre. So once again, mindfulness is kind of that step after, part of breathing. So it's a non-judgmental awareness of one's physical and intellectual self and allowing someone to focus on the present moment. And so what the theory behind that is the present moment is supposed to be safe, which of course in my circumstances is not always the case. The patient does feel quite intimidated and threatened, and for obvious reasons. They're about to undertake something that they've probably never done before. It's quite a scary environment, as I said before, full of triggers. So it's about, we do a lot of reassurance, as much as I say we don't encourage that introspection on the patient's behalf, particularly at the day surgery. We do a lot of positive reinforcement about how the operation's going to go well and how they're going to wake up in a jiffy. And we do try and try and help encourage them to feel safe. I thought the rumination came up with chronic pain. Did you want to comment on that? You're nodding like you know what I'm talking about.
Yeah, so rumination is all of the descending inhibitory pathways just don't work properly when rumination is going on.
And so they can't control their pain. So how people get. So I had a patient who had a hand injury and he couldn't put his hand down. He had to hold his hand in front of me because and that's an example of them ruminating on the injury. So they've got that hyper focus and they cannot. It's a physical response in your brain. Is that fair? It's hard for them to wind it down.
Yeah. It can lead to the behaviour changes. They're physically unable to not take their attention off it as well.
Correct. Yeah. So there's a loop that doesn't unwind. Yeah.
And then the catastrophising.
Yeah. When the work covers say that if there's a sense of injustice, the patient won't get physically better, and it's to do with that rumination as well. Like if they're constantly going back, that they feel that they're
having injustice.
Yeah.
Yeah, that makes sense.
And you hear it when they tell their stories.
Yes.
I worked there 20 years.
Yes, and they tell that part of the story.
And then I've been there 20 years, and this is what they get.
Yeah. and then they come back
Ruminating.
at an inappropriate time in the consultation to remind you. Yeah, I know what you mean. Yeah.
And there's that element of when you're constantly thinking and trying to look for what's wrong, there's more and more unsafe information that you're going to potentially come across, or just speculate for yourself. And
so they start seeing more triggers because their amygdala and everything's activated.
Yeah, they can't start finding more unhelpful information, and our brains are kind of wired to think of worst case scenario. Because if it doesn't, the consequences are pretty dire.
Yeah.
And then whenever things get missed and there's that perceived injustice, it reinforces that need to be even more hypervigilant. So if there's ever that feeling like a doctor did miss something, or an EP or physio did miss something, they have to be even more hypervigilant, or something else will get missed.
Yeah.
And then it keeps
revving it up.
Yeah.
And there's research around people, how they make sense of other people's body language and facial cues if their nervous system's activated. So they're more likely to pick up on negative affects or tones that they wouldn't pick up in a calm state. So I feel like it just, keeps rolling around.
Yeah. Keeps revving itself up. I guess the reason why I chose the title of the talk was there's a lot of that expectation that they should be able to just fix it. That it's just all in their head. A lot of patients will report to me, "You just think this is in my head," or "He said it was all in my head." Well, actually, there is a component of that whereby this system is really revved up and unpleasant and uncomfortable, and they've got a huge sense of discomfort, and that's not being addressed as part of their treatment. It's not being addressed as part of their injury. And then they say, "Oh, we'll just get 5 sessions with a psychologist. That'll do everything. That'll fix it." And I think that we're grossly underestimating what we really need to be doing. So the effect of mindfulness will, patients will report that it reduces anxiety. They can regulate their own affect, and clinicians even can be a bit more empathetic. Which would be great. And it also fosters that curiosity and innovation, which of course is a very fine line that surgeons have to tread. And I'm referencing surgeons mostly because that's the world that I live in, but we have to innovate, but not too much. So then one of the things I was listening to last week was about alexithymia, and I'm hoping I'm pronouncing that correctly, and I get the impression that this is a condition. It's not a condition, it's a situation whereby there's a continuum. So these are people who can't readily identify or describe feelings. They just never could, they never will, they never can, right? And they have an external focus, so they're focused on, say, the research into lipid nanoparticles, and they have less fantasy life, so less imaginary life, and that occurs in 10% of patients, 10% of people, not patients, and 50% of autistic patients. And I just think that we need to think about what role that plays in surgery and surgical research, and the value that has for us as a group. But that's not the same thing as a lack of emotions, which is a different spectrum. That's more your depression and your anxiety, PTSD, where the prefrontal control of your amygdala is not as good, or frontal lobe lesions. So then, of course, what happens when it all goes wrong? I've got a patient in the waiting room, he's shouting, he's slamming his fist on the reception desk, the whole room is, revved up, everyone's distressed. I think that happens in this scenario. That's never happened, but I perceive that type of emotional dysregulation occurs in medical settings because they've come in triggered before they've even walked in the door, and then we just hit them again. And so they then describe that the feeling is just too intense for them to manage, and they can't tell you what's wrong. It's like your kids. They can't tell you what's wrong, and they don't necessarily use the right behaviour to express it. So they're sad, or they're grieving and they look angry, or they're angry and upset and they weep, they cry. So the patient can, and this is in the patient scenario, they find it hard to tell you what's wrong. They just want you to do this particular thing. I just need this form filled out today. that will fix my emotional dysregulation. And of course, we spend a lot of time trying to help them identify what they really came in for and what they really wanted done, and then take them through the effectiveness and the value of whether or not we can give them the form, or whether or not we can help them with what they really came in for. So that we spend a lot of energy trying to do that. I think it's also then important for me, when I'm obtaining a consent from a patient, to understand that maybe they're going to struggle to make a decision, and we do a lot of letting the patient go away and giving them paperwork and letting them think about it. I do encourage them to talk about it with their family. And an example of that would be when I do a total shoulder replacement. If the patient's over 80, or even if they're a bit younger, I do warn them that a joint replacement is a high-risk procedure. When I was a very junior doctor, there was a known death rate associated with total knee replacements. The death rate is incredibly low now, but once the patient is over the age of 80, I do say to them, it is possible that you could die during this operation. It's possible. 80-year-olds can die. So I say to them, it is possible that you could die during this operation. Have you spoken to your partner? Because if you die, I will not be having a conversation with you. I will be having a conversation with your partner, and your partner needs to understand that you chose to do this and you felt that this was worth it. And a lot of 80-year-olds will say, absolutely, we've had this conversation already. We're both in our 80s. We understand that this is, our scenario. I have had one patient come back and say, my wife doesn't want me to have the operation, but only one. And so I then make sure that I have a relationship with the carer, and I make sure the carer is in attendance at the final decision moment, because I want to make sure that when they are completely overwhelmed with grief, that they can still understand the value of this situation to their partner. Just to recap, we all have to work with humans. I think there's a desperate hope in medical specialist circles that maybe somehow we can remove humans from the equation. Radiology maybe, pathology, but even then there seems to be some humans involved in that still. Can we self-regulate to facilitate helping someone else helping de-escalate a situation? And how do we identify others' emotional dysregulation, and how can we support them? How can we be empathetic? How can we support them? Not manipulate them, obviously. And so this is obviously an emotional wheel. The reason why I put that one up is because there's also this one and this one. And I just think when you can't find the word for your emotion, it's because there's a whole subtlety and a suite of emotions that we could be talking about. So things that we implement is naming the emotion, understanding that, yes, I understand you're angry. This is not quite aligned with, the situation you're in. No, you don't have to say that, but, I can see that this is a problem, and helping them sit in the experience of being angry or upset or whatever it might be. Noticing the triggers around them, because it's often a completely different trigger to the one that you thought it was. You thought it was you talking about the shoulder replacement, but actually it was the fact that the dog died yesterday, and they just haven't had the opportunity to process that information. But they had to get in for that appointment because they might not get another one for 6 weeks, and it's got to be done today. So I have had that experience. Meditation or mindfulness, talking through emotions. I know I'm an orthopaedic surgeon, but certainly that helps me a lot, just listening to what they're trying to process. Obviously, I do have patients that write a lot of things down. I do have patients and I do definitely encourage them to write down their questions, and we actually go through their questions side by side, discussing all the different aspects of what their concerns were. I think they come in and they're concerned that they're not going to remember to ask the right questions, or that they're going to go home. And so I do encourage that a lot, that we sort of sit down and they've had time to process, and then they can always write another list. And once we look at one list, they never seem to want another list. I don't know what that's about. Notice when you need a break, we won't talk about that. Good sleep hygiene, we won't talk about that either. Consider therapy. I think therapy is absolutely a mainstay of high performance, and if you think that you can get away without it, well, maybe ask a friend and see if they think you can. I think we're trying to perform under a huge amount of pressure, and sure, some people seem to be able to maintain regular persona, but I'm not sure that that's universal. So emotions are a physiological, psychological response to a stimulus. Feelings are an awareness of our emotions, which result in behaviours and actions. The thing I didn't say about that was it results in functionality, and I think that's something that we're judging all the time in orthopaedics. What is the patient's function? Can they go to the gym? Can they go to work? If they can't function, why can't they function? Can they clean the house? If they're not functioning, what orthopaedic problem should I be fixing? But in actual fact, there's probably a lot more to it that we can contribute. Can we modulate our own psychophysiological responses through some awareness? Can we manipulate our own emotions? And can we support others through their emotions? Go. Any questions? Was that anything new in that? Or is that what you were expecting?
It was great. It was really good.
You didn't say that with much punishment.
No, particularly coming from an orthopedic specialist. Like, that's the most I've ever heard.
Is that like a backhanded compliment?
Yeah, I get them all the time. I'm used to it.
Yeah, wow.
So your speciality is bones and muscles and stitching.
But I
things
can't
together.
afford to have that narrow focus, can I?
No.
I mean, I can see how that narrow focus can work,
Yeah.
but you need a suite of people to help you to funnel people into that moment. Do you know what I mean? Like you need a physiotherapist and a GP and an EP to have the patient totally focused on supporting that decision making to do the surgery, and then supporting all of this afterwards. I mean, I guess I'm a one-man band to a certain extent, but that's the model.
I think the process, by the time you see people, the most triggering thing for people is often helplessness and powerlessness. And by the time they're in your office, they're so far down that journey that it will be so tricky. I would imagine it's an assumption, but they will be so sensitized to stress and emotional reactivity.
They come in pretty revved.
Yeah.
And I do spend a bit of time initially addressing that.
I think just in anyone who's in pain, there's so
Yes.
much helplessness and powerlessness, and that's such a difficult position for anyone to be in.
And we would generally hope that by the time they get to you, they've seen health professionals have been able to help with that, but for whatever reason they haven't been able to. Because the reason they're coming with those emotions is potentially like injustice about it took that long to see you, and that's what they wanted from day one. Or a whole host of different things. Or horrific fear because they've got no idea what to expect because there wasn't enough information from
the other one is
referrer.
Uncle Jimmy had the same thing and he had a terrible complication, and I'm petrified it's going to happen to me.
And as an orthopaedic specialist, like you would hope and assume that all of these things have been done,
dealt with. Yeah, of
before
course.
they walk in your
that'd
door.
be great.
And because they're not expecting you to deal with this, but they walk in your door, so it's an even harder conversation for you to do to address all of these things because they're not even aware of it. They lack insight. Because in general we do, unless we have that external, and interoception and whatnot. So it's very hard for you guys. And even as physical health professionals like EPs and physios, it's hard for us, let alone the length of time you have with them, and then the expectations they have of, I know why I see a surgeon and it's this.
Yeah, I guess I just could never see it, the relationship of the patient working without addressing all the people that come in the room with them, all the baggage that comes in the room with them. I feel like I guess, we're trained to focus very narrowly on the problem at hand. But we're also trained, I had a surgeon, Andrew Graham always says, treat the patient, not the x-ray. So, it's very easy to say there is a fracture, I must fix it. But, addressing the patient's circumstances is really the art of what you need to learn in the training program.
Does that happen?
It's covertly taught, but it's not overtly taught. I did so we do a mortality review. So anyone who dies in Queensland gets a review, and it's confidential. It's de-identified, and this patient was presented as living at home, fractured wrist, 75. And that was what was presented to the consultant, 75 fractured distal radius, highly comminuted. The patient went on to die, for obvious reasons, that's why he's in the mortality ward, but in actual fact, he wasn't actually managing at home because he'd just been admitted from the nursing home 6 weeks after his fractured neck and femur. So he'd gone into the hospital, neck and femur, gone to the nursing home, broken the wrist and come back. But his notes sort of imply that he's functioning at home, living with the daughter. So that is taught, but as you can hear, the patient still died. So the patient still had an operation and died. So it was missed.
So the not fracture, he's got a 50% death rate within
Correct.
12 months, doesn't
Yes,
it? So
yes.
it was probably the knot that killed him, not the fractured wrist.
Absolutely, but the operation for the fractured wrist was probably unhelpful, and in fact the fixation wasn't able to, the tissue, the bone is just not even strong enough anymore. So there is an opportunity for the reflection. I don't know if it happened, so it wasn't prevented, but then clearly it's been brought up as a mortality audit, so therefore there is an opportunity for reflection. And so when you say is it taught, I think it's taught, but you have to be sort of out there listening for it as well.
Because I wonder why the insurance for an orthopaedic surgeon is so much higher than the insurance for a psychiatrist, when the risk of harms to the patient, I would have thought, are comparable.
I think
And is it because the patients like the psychiatrist and are less likely to sue the psychiatrist? Like what?
Might be more challenging to prove fault with the psychiatrist.
I think there's that historical procedure program.
Yeah.
Once it's a procedure, then all of a sudden it's got like a beginning and an end, and it's got a consent form, and it's got an expected outcome, and it's got a complication. I mean, I think we do get bundled a little bit in with the spinal, grouping. So spinal surgery has that very high litigation rate, and so orthopaedic surgeons are sort of a little bit lumped into that. I mean, obviously they ask us if we do it, and a lot of surgeons have stopped doing. So they stopped doing instrumenting and then they stopped doing it altogether because the insurance rate was just prohibitive. So why is the insurance rate higher? I mean, it's procedural. And I agree with you. I mean, I'm fascinated by the ability to prescribe a medication without obtaining an informed consent.
And I've got a psychiatrist colleague that actually does have an informed consent form for every medication, and he sent them to me and said, feel free to use them. I'm like, that's a bit of overkill, man.
Is it?
Yeah.
See, but that's a perception. I think, do you know what I mean? Like, I think there's a lot of patients that, that maybe they have a side effect and they really didn't hear that. They're not in a position to hear the various side effects. Like things like Wegovy, and then they say, what makes me feel nauseous? Well, hold on. There needed to be a conversation about that. Do you know what I mean? They just didn't hear it. They just want the fix. And then, I guess the other thing that I think about is the patient comes in with a problem and they give it to me. And then when it's all fixed, they'll take it away again and it's all done. There's that compartmentalisation, that externalisation. I try very hard to wind that back, and I think also with physio EP, you've got to wind back that, I'm going to the physio, and the physio is going to make my back better. You've got to wind that back and ask what the contribution that the patient is capable of making. And as you both know, as you all know, if the patient is completely incapable of making any contribution to their care, then the physiotherapy might not be successful.
Insert am I?
No?
Insert motivation anyway.
But as far as
stages have changed.
Yeah, so when you're talking about motivational interviewing, are you talking about interviewing them to see if they're motivated or interviewing them to motivate them?
Yeah, that. So you ask them questions in a way that they say the things that you want to
That's
tell
what
them.
it's
Motivational manipulation. It's not interviewing. Interviewing sounds like it's a to and fro
It
conversation.
is a two-hour conversation.
You would have loved the
You should
conversation.
do Suzanne's course, you'd love it.
Okay, I'll do the course. Suzanne.
Habib, the psychologist that works with me, she actually runs a MI course.
Course. Okay, alright, I'll give it a go.
And there's an amazing book. I think it's just called Motivation Interviewing for Healthcare Professionals.
Okay.
I think it's probably one of the best books I've ever read. clinically.
Oh, that's a big call.
By Resnicow and something else.
Okay.
It's so good.
I'll read the summary.
Yeah. And that course will be amazing as well.
All right, I'll give it a go. Because it affects, my whole career, every aspect of my practice.
Helps in personal life as well.
Especially when you talk to your wife.
Teenagers.
What was that?
Teenagers.
For your teenagers, yeah. Any questions?
I think I was struck because I'm often thinking about it from a patient point of view, and I see so many people who the problem is not the feeling, the problem is the repressing the feeling or the anxiety about the feeling or the worry about the anger. And I spend a lot of time trying to get people to feel safe with feelings.
Yeah.
And so then flipping it and thinking about it as a surgeon or, as a health professional in an acute moment of how incredibly adaptive it is to be able to repress feelings and do that.
And how we need to do that.
And how you need to do that, but then, like you mentioned then, being able to come out, debrief, and actually then process the feeling rather than just repress, and then
Wait for it to
it comes out some other way.
I mean, I think we're trained to do that. You said, what are we trained to do? I think we're certainly trained to repress it.
Yeah.
And then, but there is a formal nowadays, I mean, not back in my day, a long time ago, but then there is a formal debriefing process, and we are taught how to debrief and how to manage the trainee and how to have that conversation.
Which is so important because you've had this complete nervous system response,
Yeah, true.
which is unavoidable, and then how you navigate that and.
Well, then the question then is, do you do the next case? Because of course there's extraordinary pressure. There's a patient waiting for their operation.
Yeah.
So how do you identify if you're in a situation whereby you can actually process enough cognitively to do the next case?
What's the length of the debrief usually?
Well, I mean, that obviously the focus of the teaching about debrief is in the context of a death. So the scenario becomes a death. And then, of course, we don't need, clearly the rest of the list is cancer. There's no capacity of probably any member of the team to actually contribute effectively to the next case.
So, do all surgeons do that, or is that your protocol?
No, that's what we're training them to do, and that's what that's what I would expect in Queensland Health Public System, and I'm pretty 99% certain that that's what happens over the private.
Because I had a theatre staff member tell me otherwise.
Recently?
Yeah.
Well, that's possible. I mean, it's not like a rule, it's like a guideline.
She thought she couldn't return to work because she couldn't believe that this had happened, and 15 minutes, next patient's on the bed kind of thing. Like.
Well, some people feel that I can understand how that happens, and that was the way it was always done. And you're right. I don't think 15 minutes is long enough for a debrief. There's a structured format, to identify, what were the issues and as the surgeon, we're supposed to manage all this, and the entire team, the whole world will do everything. But there's a format whereby, you give everyone the opportunity to speak up about what they were concerned about. So we have speaking up protocols whereby, like pilots, whereby you say, I need to draw your attention, I need this is something we need to address now you need to stop. Right? So we have speak up protocols. So once again, with the debrief, then there's got to be an opportunity for them to speak up about what they perceived were the events that led to the adverse outcome. So it's about identifying those things and giving people the opportunity. Like you can imagine that if you don't have time to say, but wait a minute, if we do this on the next patient, this might happen again. So, people need the opportunity to debrief on that. And then also, checking in with what people's capacity then is to continue. And I mean, I think sometimes they just manage it. There was this perception that, we'll just swap the team around. We'll just give the surgeon a different team while the other one has a break.
Does that happen? Or does
That's how it used to happen. Fresh team! Yay!
Blue glasses. I thought you were over there before.
Absolutely. Because of course, certainly orthopaedics came from wartime surgery. So it's all, MASH and TENS and kind of, next patient So, you know, there is that very old culture, you know, maybe it's not that old, 60s, 70s, whereby, you know, next patient, yeah, absolutely. But you know, there's a lot more.
So currently you don't have, like, if one of the team
Yep.
says, we just had this you know, horror moment, I can't go on.
Yep.
You can't
The current,
them?
the current arrangement would be to substitute them.
Yeah.
But I can tell you there would be an extraordinary amount of pressure on them to stay.
Yeah. So this is what I want to go on that one is because the perceived pressure to continue on.
Yeah.
When you might have an evaluation itself to say, I can't
I'm not
perform
ready.
at the level that I should.
Yeah.
But the peer pressure is overwhelming.
Absolutely. And so, you know, obviously there's been moments in my career where I've said, I don't feel safe, I'm not prepared to go on. And even saying that feels very unsafe, right? Because you don't know what your team's going to think next time you're under pressure, right? So we've had incidents, I don't want to talk about that one. I'm trying to de-identify an incident.
Still suppressing that one.
You just want to say, I heard about this one time. You're just like,
I'm just trying to think of, you know, things that happen. Because as I say, there's an awful lot of humans involved in doing an operation still. I mean, I'm sure we have robots, but, you know, there's the story of the lady who was operating and her waters broke. You know, do you keep going or do you just tuck out? The surgeon was, yes.
Oh, okay.
Surgeon was operating and the waters broke. So what do? You keep operating? No one there. No one to come in. You wait for the contractions to get really bad.
Yeah.
Do you know what I mean? Like,
Yeah.
what do? We don't have a plan. Like you say, what's the strategy for these sort of situations? Does she finish the list? That's a bit rugged.
Yeah.
Or, you know,
Mop my brow.
pardon me? Not your brow.
Mop
My brow?
Yeah.
And the floor underneath.
And the floor.
Well, you see the water broke, so
I know.
Don't
It's
sleep
concerning. But yeah, I often have to ask for water. That's quite confronting, asking for water, you know, during a procedure, especially if it gets a bit long. Sometimes that's difficult. But you know, we are trying to introduce these, you know, stop and check systems and then debrief systems. And I guess what I'm trying to say tonight is that we are trying to deal with the fact that there's lots of humans in an operating clinic, and we're, as you can hear, we're way behind what you think we're doing.
So even though this is like the proper medical talk, and like that's not my field, like for clarity, like I drive tugboats, but you still have that
checklist.
You still have that. You're working in a team, and you have situations where you can't just go, I got to step out or whatever, because you might be tied up to a ship and in a critical part of the manoeuvre, but you still have that. Like once all that's finished, you have that debrief moment. You know, you positioned in the wrong way, or the conditions. You know, we should have called it because of the conditions, and you know, even like the whole human thing comes in because everybody has something going on. Everybody. There's always everyone's always got noise, and even more so now, we're overstimulated by everything. And space, creating the space for people to have their own time to reset. It's like I found in like managing the crews, a lot of the problems fix themselves by creating space, because they need to process what's going on. Because if people are just getting lumped with another thing, like those small percentages, 1% or points of percents, they all add up. And then it takes one thing, and then you go, oh, well, the guy was triggered because, you know, so-and-so asked him to tighten that. But no,
There's a whole lot of backstory.
it was way back then.
We get that theatre all the time.
We all get overwhelmed. You know, you turn your TV on, it's overwhelming. You know, you get these messages from random scam calls. That's another. You know, we are in an overstimulated world. We need to create space.
Finish on that note. No, sorry, Dave.
Have your space, get out.
How common would this knowledge be amongst your peers in orthopaedic specialists? Which is
Oh, you mean formally like this? Zero?
and how
Informal?
well do you feel that would be received with orthopaedic?
This talk, this kind of conversation.
Yeah. And for context, the reason I asked,
Yeah.
when I was in op
When you got a
rehab,
dog me in. Maybe do some talk or something awful.
no, so when I was in op rehab, I used to get requests, and the systems make it hard because it asks specific questions. It asks biomedically orientated questions like,
What's this? What's content?
like in IME reports, where I'll ask the specialist, like, what's the cause of the pain?
Yeah.
Now, ask it with no opportunity to really even comment on the human. They're commenting on the image
Mechanism?
or, all the
Pathology?
structures. And there'll be a question at the end and it says, are there any other psychosocial
Correct.
factors?
Every single report says, is there any psychosocial factors? I always used to say, I am not a psychologist. If you want to know the answer to that question, you need to ask the psychologist because that is not my area of expertise. But go on, what do you put? you just put the whole psychosocial box.
So now you have more things to put in that box.
See my slide. See my Facebook
Well,
page.
it starts with the amygdala.
But I mean, there you go. It used to be that the way that question was phrased was that, sometimes people would have a single additional traumatic event. So here we are, with their shoulder pain after they've fallen off scaffolding, or actually their dog died, or their mother's sick or something. So there was that very much, this person has had a significant psychological trauma in, timely relationship to the injury. But I think what you're saying before is there's noise, right? Everyone's got lots of little things all the time, and obviously they have a big thing. So if there's a big thing like, they've had to move house, or, they've lost their property or their home or something, then sure, that's what they're chasing, is there an additional psychosocial stressor of similar magnitude to the injury that could be affecting their recovery. But you're right, it completely ignores the whole rest of it.
Yeah, and is there intention to be able to find a way to disprove the claim? And it seems like that's more like the case in IMEs as opposed to what do we need to treat? Because, their dog may have died, but that person is still the employee. Their recovery, the thing that happened to them, physical or emotional trauma, still happened to them. And not to just a person that has no voice.
I feel like there has been a de-emphasis on answering that question. So I feel like in the IME space and the tribunal space, there is much less emphasis on what they perceive as psychological concerns. So a surgeon, generally speaking, is concerned about the number of tattoos a patient might have. They're generally concerned about their dentition. They're concerned about their general physical clothing that they're wearing, and they're concerned about whether or not they've got shoes on. So those are the things that orthopaedic surgeons find not triggering, but distracting. And so then we used to be able to say that, this patient appears dishevelled, this patient is well dressed. You'll sometimes see that still, neatly dressed, because they're commenting on the person's functional capacity in the context of their psychological.
Just giggling. There's a lot more to it than that.
So they do sort of answer the question a little bit in the context of their ability to dress themselves and turn up. I had one patient who came in with after he'd had surgery for his back, and he was extremely happy after his back surgery. He was seeing my boss, and as he was leaving, he sort of seemed to be sort of shuffling a little bit because he was really uncomfortable. And I was like, "But you just said your back was really good." And he said, "Yeah, but my feet are really sore because I borrowed someone's shoes and they're too small." Because he didn't have any shoes, but he made sure he wore shoes to the consult. Because there's something in that. I'm a little bit oblivious to it, but there's something in that that somehow that describes their psychological status. And that's what they're chasing in the IME, is does this person have the functional ability to dress themselves?
That, what you described in there is like, when people play up and they have to front court.
Yeah,
and
probably
they
the
wear a
same.
suit.
Yeah, they wear a suit. Yes,
They probably
correct.
never worn a suit,
Yes, yes.
you know, up until that day, but now they've
Yeah,
got
we'll wear a
front
suit
the
for
judge,
that.
so, you know, that would, you know, I would interpret that as the same mental
Yeah, I
space
think
as
it's
to say, oh, I've got to go and see someone that's going to review,
Me,
so you need to be like,
at peak.
Which means that things that are contributing to their pain may not be picked up because
Yes,
they're
well,
needing
yes.
to
So that's been the
repress
subtle
and
change in
suppress
medical
and-
practice is to allow
Yeah.
people to
So the
feel
questions
comfortable
are
with
wrong.
themselves. Yeah,
the
yeah,
question,
yeah,
you need
yeah.
better questioning,
The question's not right anymore.
because you're not getting the information
that we really need.
that you need.
Because as you're saying, when they introduce noise into a claim, if you never address the noise, you will, I don't believe you'll ever get a patient who has had a satisfactory outcome from, say, their claim or their treatment. But that's a perception. I don't know how real that is.
And the irony is it would probably be cheaper in the claim if they actually just addressed the noise at the start rather than.
Oh, I think it would save a lot of time. Yeah.
Rather than I was actually for another time.
You just edited that one, didn't you? The prefrontal cortex just came in.
Not back on.
So we can, on that note, we'll stop the recording. Is that what you're saying? Thanks very much.